Goals of ventilation, I mean, Dr. Kavita clearly mentioned that the main aim is to maintain oxygenation and ventilation, and we have to be careful when we give oxygen. So treat oxygen as a medication and dose regulated, use it only as needed. Your targets are specified so that you don't overdo, and where the lung disease is severe, you may titrate your targets downwards as well. So disease specific ventilation comes in. So oxygenation is the first goal, and effective ventilation, which is to maintain the CO2 levels. Again, CO2 levels depending on the condition of the baby and the age of the baby. So the threshold can vary. You have the concept of permissive hypercapnia. So previously we used to be aggressive with permissive hypercapnia, but after the Felbeat study and other studies which showed that the babies with the significant high CO2 may do worse, we are titrating it on the medium side. So it's not too aggressive, but according to the age, in a premature baby, the hypercapnia can cause brain injury, in vasodilation and IVH risk. So in the first week, you have to be more careful. Again, when you look at CO2, the first thing is to look at what is the source of your gas. If it's a capillary gas, is it arterialized enough? If it's a venous gas, you don't really worry about the CO2 on that. So if it is an arterial gas, the value is different. If it's a capillary gas, the value you take is different. So always get into the habit of looking at the source of the gas before you comment on the CO2. In a baby who is very sick from sepsis, or you want to reduce the pressure to the tummy through NEC and so on, you want to minimize the work of breathing in these situations. And in any ventilated baby, you don't want them, you're supporting the breathing, you don't want them wasting their energy, because nutrition is in the background for all these small babies. You need to conserve their energy. So minimizing the work of breathing is one of the goals as well. And avoiding complications. Anything we do in medicine, our aim is to avoid complications. So do no harm first. And that principle applies to ventilation as well. But we need to know what are the complications. So we have ventilation-induced lung injury, barotrauma, volutrauma, atelectotrauma. So there is some discussion that barotrauma may not matter, but remember that we cannot predict how much pressure is going to lead to how much volume. So indirectly, you have to monitor the pressure as well. Don't say how much pressure I give doesn't matter, because there is no barotrauma. It's a volume that traumatizes, but you cannot control how much the pressure is going, because the complaints keeps changing. So you have to monitor the patient. Pressure does damage through the volume it delivers. So unless you regulate it, you cannot control it. And ventilator associated pneumonia, in addition to the lung injury, you also have infection from ventilation. So chronic lung disease also, partly because of the prematurity, partly because of the oxygen, and partly because of the oxygen use. So